All right. Well, what an opportunity it is to get to discuss this topic of group medical visits with you. We have been, thanks to a micro research grant, my husband and I, Jacob, and myself, Jacqueline, have been implementing group medical visits specifically for chronic pain in the rural setting. And so today I invite you to see how this might apply to your community, your setting, because we've been asked to really share our experience and our advice and why this would be so pivotal for rural. And it's really exciting. I hope that you can feel our passion and excitement for the results that we saw in rural Shoshone, Idaho. So first of all, can you feel the weight of chronic pain like we can? It seems like everyone is talking about this on webinars and the news and just even in the clinic, with having about over 100 million Americans affected by this chronic disease. It's the most common disability and chronic disease that we see in primary care specifically. And it's only going to get worse, unfortunately, as the prevalence of rising obesity levels and the aging demographics. So we can feel the weight, and I think you guys as well can too. Specifically, we can feel this in rural situations, and why, as we kind of discussed with the prep materials and questions, there's specific elements of rural that make chronic pain even more difficult to manage, whether it's because access to care or financially or socially or just to the population. As the screen shows, there's a lot of elements of rural that make this difficult and challenges. Specifically, there's few rural chronic pain evidence-based solutions. We know chronic pain is a problem, but there's few solutions that have really been implemented in chronic pain with rural. And then also, as talked about in the pre-material, stigma. A large percentage of people with chronic pain are affected by the stigma that affects their self-esteem and their self-efficacy, or their confidence and inability to manage this. And why does that matter? Well, as we know, when we, as practitioners, try to create a plan for someone, let's say, with abuse, or substance abuse, or cigarette abstinence, or things like that, we can't just go to them and say, okay, today's the day, everything's going to change today. And our plan, we need them to have self-confidence and ability and understanding to manage it, and control and desire to manage it. And that's the same with chronic pain. Despite even the most effective solution, it has to come from the patient to be motivated and encouraged to do that. So that's another challenge. And then also, specifically that we see in rural, also the lack of pain specialists and multidisciplinary pain programs. And we know interprofessional options are so much more effective, but it's difficult to be able to have that in a rural setting. So group medical visits, having a visit where the individuals involved, usually about 5 to 10, all face the same chronic disease, are an innovative solution. Surprisingly, experience and research for over a decade involving over about 100,000 patient visits have demonstrated that GMVs, group medical visits, in primary care can lead to increased access to care, enhanced quality of care, and improved patient and clinician career satisfaction. So why don't we use it? There is a huge gap in actually applying group medical visits, despite their effectiveness, especially in rural. In some research, it was estimated that only about 10% of primary care practices, which I actually think is maybe even inflated, actually use and access GMVs. But even specifically, even less are using them for chronic pain. Most often, GMVs, in the research and experimentally, have been used for diabetes. So our project is exciting because we took a really innovative solution and tried it out in rural. And we have had experiences with rural, and to be able to see. So what we did is we conducted 5 bi-monthly 90-minute GMVs, group medical visits, between October and December of last year at Shoshone Family Medical Center, which is a rural family practice clinic in Shoshone, Idaho. Shoshone is located at that tip of that red arrow in Idaho, and it's in Lincoln County. And surprisingly, and though Lincoln County is the size of Rhode Island, it only has one medical clinic, and that's probably why it's ranked 43 out of 44 on the quality indicators, being as one of the sickest counties in Idaho. Now there's Main Street, a little look into Shoshone. So exciting. What did we find in this project? I'm going to give you the summary at first, and I'll go through each of them. First, self-efficacy. That the patients were able, their confidence to manage their chronic pain, enjoy life, and do what they needed to do. We had a specific questions on that increased. We had questions before we started, after the first session, after the first month, and at the end to be able to assess these things. Then also the quality of life and their ability to do their daily activities improved. Their overall satisfaction with the groups, and just even their perspective changes and things that they learned were really incredible. And I will share those as we go through. So one of the questions was, on a scale of 0 to 10, rank your confidence to manage your chronic pain and enjoy life and do what you need to and want to do. And this increased over 26%. We also had a question, these are two of the questions. How do you feel like you understand your chronic pain? And it was so interesting because we asked them in this order, but then also we switched this order to see if it was based on the order of the question. Everyone always would rank their understanding relatively high, but then their confidence in managing it and being able to enjoy their life and do what they wanted to do was always considerably lower. However, through the course of our group medical visits, the gap of this understanding versus their self-efficacy, their confidence in being able to manage it, decreased by 43%, meaning that their overall understanding increased and their overall confidence in their ability to manage their chronic pain increased. And that is incredible. Also, we had conclusions on based on questions we asked about quality of life and general activity, in asking how much their chronic pain interfered with what they were doing. And we saw that specifically in the activity level, that chronic pain did not interfere there. It improved, or it didn't interfere by 25%, which was really incredible. Then we go to satisfaction. That's something that people worry about. Are they going to be as satisfied with these group visits as they are with individual visits? And at Shoshone Family Medical Center, when compared to their regular visits, their satisfaction increased by 19%. How incredible to have a solution that can help their overall satisfaction. We also ask questions about not only their overall satisfaction, but their desire to continue utilizing. And from a scale of 0 to 10, 0 being not satisfied at all, and 10 being extremely satisfied, you can see the numbers here are incredible. Their desire to continue utilizing and how satisfied they were with the amount of time and personal interest were close to a perfect 10, which is incredible when asked over several different individuals. And then how satisfied they were with the tools and information that the visits were giving them to help them manage was also an 8 out of 10. So, you know, one of the things that individuals, practitioners and participants worry about is the timing. Are they going to be as satisfied if they're in a group versus individual? Are they going to be satisfied with the overall attention? And we saw that they definitely were. This is the most exciting part for me, was being able to facilitate these groups and hear from these patients and participants. Overall, the resounding theme was that listening to others with similar problems and finding common ground, the word that individuals use most on our qualitative questions was honesty, that they enjoyed being able to be honest about how they were dealing with their chronic pain and managing, and hearing others honestly express how they felt. This was incredible. So that stigma that we initially talked about, that sometimes is the case in rural, we In fact, our patients loved listening to others and sharing, and that concerns of confidentiality was not an issue in our group. One of the most powerful moments was that when a patient shared, she said, you know what, my course treatment in chronic pain really changed when I decided to, instead of look at my pain and decide on the effectiveness of the treatment based on a 0 to 10 pain scale, instead of looking at this and using this as the judgment and the assessment marker for if my chronic pain was effective, because I realized I was never satisfied. My pain was never a 0. I instead decided to focus more on my function. And in that, I had a turning point in my management and care. When she made that comment, I could see everyone else in the group look around, internalize what she said, and really desire to have a perspective change. And I, as a facilitator, did as well. Instead of focusing on pain as the 5th vital sign, 0 out of 10 pain, and using that as my guide marker, using their overall function. And that was empowering to her. And to hear that from a fellow participant with chronic pain was powerful. We also discussed topics. One of the most surprising to each of the participants was morphine equivalent dosing. No one in the group had heard of this or understood this topic. We invited a pharmacist to come at this time, at this session with us, and help explain these principles and discuss them. It was so interesting to hear these individuals talk about, wait, morphine isn't the drug that's the most powerful? They all thought it was because they had several friends on hospice and that had passed away, and that was the drug that they were last using. But we know that most often it is used in hospice because it's a really convenient sublingual option. And when they realized that the opioids weren't just, the strength weren't just based also on 5 milligrams versus 20 milligrams, but actually what the medication had, it was eye-opening to them to be able to better understand their treatments. So that was really exciting for us. Also, a participant expressed, pain is lonely. And these group medical visits are powerful in the ability to share. And then also they became so open. We had an individual being willing to ask their own questions and say, everyone, what do you think? One participant said, I have a surgery coming up, and what am I going to do with my chronic pain? Because all I'm going to be doing is sitting in my bed and thinking about my chronic pain. It was so amazing to be able to see other people start saying, well, here's some things that I've done. Here's some things that I would recommend. Here's applying what we've learned today. And so our experience was phenomenal. So now I'm going to transition into some tips specifically generated from our rural experiences on how to get going in implementing your group medical visit. First, it's easier than you think. I've talked to several people and they think, oh, I've wanted to do this for a while, but I just don't know how to start. Don't worry. Just decide that you're going to start thinking about it and you're going to do it. Then you're going to need to decide what chronic disease do you want to focus on. I'm biased toward chronic pain and saw a huge impact. Lots of research has been done on diabetes and some asthma, obesity, depression. So for your clinic, start thinking about what would be perfect for your area or community. Then you're going to need at least 3 people total. So you're going to need at least someone to facilitate the visits. Secondly, you will want to have a behavioral health care provider. We used this and it was powerful. She was able to contribute on the content that we were providing and discuss, and then also the participants felt comfortable to discuss things with her afterwards. It provided access in this rural setting that they hadn't seen or been able to use, and it was advantageous for her to be involved. She wanted to be involved because then she received more referrals and felt more connected to the community and to the clinic. Also, you'll want to have at least 1 support staff to help check in people, check them out, and so on. So here's some pearls that we learned. The first, in recruitment, it's all about the invitation. Don't waste your time in cold calling people or things like that. You will want to have a direct initial provider invitation. For example, I as a provider would go to Susie and say, thank you so much for coming to this visit today. We have an innovative solution in our clinic that's just starting, and I feel like you could be a real contributor to this group. Each person needs to feel that not only will they benefit, but they will also contribute. This initial provider invitation will help in the actual attendance and the retention. We averaged 7 participants. We had a goal to having 5 to 10. We had 7, and in fact, not only did our attendance increase, more people wanted to participate as this went, which usually in things of this nature, you'll have one visit and then it's difficult to have people come back. They've used group medical visits even with homeless populations, and they've seen that the retention is incredible. You can then use, text or calls per the participant's preference to remind them of upcoming visits, but that initial invitation is very key, especially in rural. You have unique connections with those patients in the community, and having the providers who have trust with them invite is a huge key. Then the details and the location. I'll discuss this briefly, but you'll want to have like a boardroom where you have, like a whiteboard on one side and a place to present some material. For our content, we used research-validated cognitive therapy module, and there's the links in the resources. Really wonderful is that it's free. We're not sponsored by them by any means. And they have an online free literacy adapted manual, which was very helpful for rural. It really drilled down principles that are effective for chronic pain management, but in a very simple way. Then remember, the content for your group medical visit, it is not a lecture, like kind of what I'm giving now. It's a discussion. So you can expect to have the participants provide about 75% of the content. You will introduce a topic, and what is really effective is a pearl, is to have PowerPoints that have discussion questions there listed so individuals can start thinking, internalizing, and sharing. And then you'll want to think about your facilitation skills. And I can guarantee you that there's going to be some individuals that are more silent and some that are more kind of overbearing and want to share. And it's important to be able to balance each person and make sure that each person gets to contribute. Here's a slide on the content that we used and our content topics. Again, we had 5 topics. The first was the relationship of stress and pain. That was eye-opening and really a wonderful discussion. One on cognitive behavioral training. The third was on physical activity and sleep and how they, play into each other. The fourth was on mindfulness. And the fifth was on specific pain medications and educating them about their medications. Now, I have to admit, when you're used to having a 15-minute visit, a 60 to 90-minute visit can feel daunting. You think, how's that going to work? Trust me, it goes by so quickly, at least it did for me. And here's some pearls, I'll go through them quickly. First, once everyone has HIPAA consented to share their information, being willing to share their information in a group setting, don't make them check in and wait in the waiting room. Have them meet in the meeting room where they are going to gather, because you'll see how these interactions just start happening. Then the first 15 minutes will be an introduction and a key pearl. If you remember nothing more than this tip to implementing group visits, the first visit needs to be focused on each individual introducing themselves and sharing their pain story. This is powerful. And when individuals make comments and have questions, it's powerful because we understand where they're coming from. And this is what the participants resoundingly said they enjoyed the most. Third is going to be the actual content. When you start getting into that, you can count on that being about 30 to 45 minutes. But remember, it's not a lecture. And having a hands-on activity, actual handout, we did that a couple times, is really helpful. And then if you wish, the last 20 minutes, you can pull people out individually. And because you've prepared, you can discuss specific labs or prescriptions that need to be changed, which is very effective. And then the last 10 minutes can be a conclusion. So just get started. You can do this. And it is so exciting how it's a benefit for the providers for the participants and for the healthcare system. Conduct your first group, and then it's a snowball effect. You would not believe. After we finished our first pilot one, we had people coming to us saying, look, because I expressed that at first it was difficult or kind of hard to think about how to recruit until we got this key of having the providers invite. And they said, don't worry about that. In fact, we will sponsor people. We will personally invite the next participants to come. We will sit in with them and we will continue participating. We want to keep doing this. So once you get one going, the rest you can do. Here's some amazing resources. The top two I would highly recommend. They're also recommended by the Agency for Healthcare Research and Quality. Really kind of some details on how you can get these started. They're links and you can go through that. The foundational texts, Nossinger is known as, and those are listed, his books they're listed if you would like to have a text resource. Also, the content that we used are there. A self-efficacy questionnaire is there if you want to be able to assess how things are going. And then if you have questions about billing, this is really effective for providers as well, because you can bill for 10 individuals or however many you have. And there's a little graph here on the coding and things like that included if you would like to see. But really, group medical visits, our actual case or our research was consistent with what is being the opportunities to help decrease pain ratings, overall increase quality of life, decrease opioid consumption costs, and provide opportunities to educate. So I hope this is just a starting point for us, and I would love to collaborate with the different issues that you have in your setting or questions. Feel free. I would be welcome to share anything that we used, including, you know, our PowerPoints that we used to start discussion, if you have any questions. So thank you.